So, I'm very thankful to Ragbanshi Sabu sir and the whole organizing team of Diabetes India for giving me this opportunity to be in front of you. Thank you so much, everyone, and my greetings to all of you once again. What is dementia? It is a very important problem to which we frequently do not pay so much attention in our regular practice. We've had a lot of discussion about almost we've seen that all the talks that have been on the elderly have touched on this topic, so we can understand the importance of it. Dementia is now termed as a major neurocognitive disorder. This is the terminology which is now used. This is a modern terminology under the DSM-5. It is a denotes significant cognitive decline from a previous level of performance in one or more cognitive domains confirmed by clinical assessment and or standardized testing that interferes with independence in everyday activities. So dementia basically is an umbrella term which talks about not only one single condition but many conditions together, and together they are brought under the umbrella of major neurocognitive disorder. So the key components of dementia are that it is acquired, it is not developmental, it comes with age, with risk factors. And another important thing is it has to be progressive. It is progressive. It worsens over time, unfortunately, as we all know that there is no treatment for dementia as of yet. And there has to be impairment in cognitive domain, executive function, attention, or language, or visual spatial skills, social cognition. So at least there has to be impairment in one cognitive domain for it to be termed as dementia. Then there has to be functional impairment, which should affect the autonomy of the individual. It should affect the work, finances, medication, management, or tasks of daily living. And this should not be explained by delirium or any other psychiatric illness. So when we have all these things together, it can be termed as dementia. Now the numbers, portion of individuals who are having dementia. So the risk of dementia rises with age, even though it is quite paradoxical. In diabetics, we'll come to it later. So almost in age of 65 to 74%, almost 5% individuals would have dementia, and 75 to 84 years, 13%, and 85 plus years, 33%. And the lifetime risk of dementia after the age of 55 is almost to the tune of 42%. So we understand the enormity of the problem that may be. So these are age-related risks, as we have seen here. Now, coming back to our country in India, almost 7.4% of Indian population, adults above the age of 60, have dementia. So that brings out the total number to 8.8 million Indians above the age of 60 are affected with dementia. And globally, there are more than 47 million individuals with dementia and projected to rise to 131 million. Now, as I said, that dementia is not one condition, not one disease. There are many diseases which are brought together under dementia. There are almost 13 subtypes of dementia in DSM-4, but the most important and prominent of them being Alzheimer's disease, which accounts for almost 70 to 80% of cases, and it is characterized by amyloid plaques and neurofibrillary tangles, that the hyperphosphorylated tau proteins that we've all heard of. Vascular dementia contributes to 15% of cases. These are more stroke related with lacunar infarcts and microvascular disease. Lewy body dementia accounts for almost 5% of cases. It is attributed to alpha synuclein protein aggregates in the brain. Frontotemporal dementia is in lesser numbers because of TDP3, TDP43 and tau proteins in the frontal temporal lobes. It is a very specific type of dementia. But the majority of dementia that we see in diabetes is the Alzheimer's and vascular being more prominent. There's also an emerging entity, the diabetes-related dementia. It is different from the dementias that we had discussed till yet, and this has been outlined in the ADA guidelines. So it is a distinct form. It is diabetes-related dementia and is emerging distinctly from Alzheimer's and vascular dementia. It is characterized by slower progression, absence of neurological, typical neuroimaging findings, and unique clinical features. So with long diabetes duration, no typical imaging, advanced age, and elevated HbA1c with slower progression can be termed as diabetes-related dementia. How diabetes damages the brain and it accelerates the process of dementia. One is chronic hyperglycemia, which leads to the formation of age, in which glucose covalently binds with the proteins and changes their structure. Inflammation, especially the microvascular complications of diabetes, lead to neuronal injury and ultimately the change in the synaptic plasticity, leading to the changes which attribute to dementia. And one of the reasons why it may be more prominent hypothetically in type 2 diabetes is because of profound insulin resistance. Because the insulin degrading enzyme is the same enzyme which clears the beta amyloid in the brain. Because of the profound insulin resistance and insulin excess, the beta amyloid competes with insulin for clearance, and the clearance of beta amyloid protein is decreased in the brain, which would lead to the Alzheimer's dementia. Inflammation is a very important part of the pathophysiology of dementia. We know that diabetes is a disease of chronic inflammation. There are genetic and biochemical biomarkers. There are genetic predispositions. The ApoE4 is a dual risk factor. It impairs lipid metabolism and amyloid clearance in Alzheimer's. Then biomarkers, the butyryl cholinesterase activity is altered in diabetes. Now how diabetes intersects with dementia. Diabetes dramatically increases the dementia risk, as we can see here in this forest plot. In these different studies, we have seen that in all the studies, persons with diabetes have a much greater risk of dementia. The overall risk in a meta-analysis of 8.8 million participants was 1.59 times, vascular dementia 2.5 times, and Alzheimer's independently in type 2 diabetes 1.5 times more. And must be noted here that in some studies it has been found that women are more prone to dementia as compared to men. Type 1 diabetes and dementia risk, this is a study from the Swedish National Registry, and it has shown an all-cause dementia risk increase of 2.02 in type 1 diabetics, and as you can see here, the vascular dementia risk hazard ratio is 3.73, so much more increased vascular dementia in type 1 as compared to Alzheimer's and non-Alzheimer's dementia. Duration matters. The duration of diabetes is very important. Some studies have shown that there is almost 29% increased risk of developing dementia even with the diabetes duration of less than 5 years, and to be exact 4.8 years. So that means that even at a shorter duration of diabetes, the risk of dementia considerably increases in such patients. Now, the dementia risk over lifetime, we have seen that some studies have shown that even under 45 years of age, there are greater hazard ratio for Alzheimer's disease and vascular dementia. In middle ages, there's moderate increased risk, but in the older ages, beyond the age of 75, the risk of dementia, if the diabetes is diagnosed at the age of 75, then the risk of dementia increases much more significantly in such individuals. Next, we come to the diabetes control, diabetes management in such patients. So there's this Accord trial that we all know about, and there was an Accord Mind subset in the same trial, which compared intensive glycemic controls versus usual control. So that has shown that intensive glycemic control does not decrease dementia risk. So this has come out in many other studies also, that dementia is the development of dementia and risk is not subject to the control of diabetes. So people who are having very good control of diabetes also may develop dementia, but there's definitely a link between depression and dementia, which was again a finding in this trial. Hypoglycemia, we talk a lot about, is actually very important and one of the most significant factors in increasing the risk of dementia. So the overall increase in risk in with hypoglycemia events is 56%. Even with 1%, one event of hypoglycemia, it is 1.29, and with 2 events 1.68, and with 3 events 1.99. So as the numbers of serious hypoglycemic events increase, the chances, the risk of dementia increases. Then the other important thing is that there is the bidirectional relationship between hypoglycemia and dementia. Just as hypoglycemia may increase the risk of dementia, dementia increases the risk of hypoglycemia because patients, individuals, they are not in they cannot take care of themselves properly. How hypoglycemia per se damages the brain? It leads to energy failure, ATP depletion, especially in the hippocampus, which was talked about in previous study with Dr. Ajay Tiwari also. And before that, oxidative stress as a result of hypoglycemia, inflammation, and free radical damage occurs to neurons. Excitotoxicity, glutamate, NMDA activation damages neurons, and vascular dysfunction, microvascular and endothelial damage also leads to dementia. Screening for dementia is recommended by all the major bodies, and there's a big chapter of screening of dementia and dementia in the elderly in our own RSSD guidelines. So, ADA also has recommendations for screening of dementia in individuals at above 65 years at initial visit, then annually, and going by the symptoms as it may be appropriate. But screening is very important. How to do that, we'll go about it. And the basic recommendations for screening are similar in the RSSA guidelines, so I have not put them. The screening tools have been discussed in previous talks also. So one of the most important screening tool is the mini-mental state examination. It is a comprehensive cognitive assessment test, which does not take a lot of time to be administered. So some basic questions need to be asked for orientation, the date, time, registration with the patient registers, what has been shown, and the recall of these objects that have been shown, then spelling word backwards, and doing understanding simple tasks and doing simple tasks like following language command and writing a sentence. The other important test is MOCA, that is Montreal Cognitive Assessment, which may help in identifying sensitive to mild impairment, and it has, as you see here, a visual spatial executive tests to copy a cube or draw a circle or a clock, name animals, check for attention, language by repeating sentences, abstraction, and delayed recall. And points are allotted for these activities, and the results is assessed by that. Coming to pharmacological management, I am not going to touch on the pharmacological management of dementia per se, because that is only supportive. There are newer agents like aducanumab, which has been approved by FDA for management of dementia per se, but our concern here is the diabetes management in patients with dementia. Some meta-analysis, this meta-analysis has shown from many studies that GLP-1 receptor agonist may help in decreasing the incidence of dementia and better outcomes in dementia. There are other studies also. Some studies have shown improvement in dementia with SGLT2 inhibitors, specifically the vascular dementia. Some studies have shown mild improvement in dementia with thiazolidinediones also, but there is no specific data which would help us in prescribing, giving us guidelines to prescribe these particular agents. There are no specific such trials which have proven their benefit. Lifestyle interventions perhaps are still the most important ones, which are very helpful in delaying the progression of dementia. There have been different trials with all these different modalities. This finger study in Finland with diet and lifestyle, mindful breathing. So these are all studies which I am showing you here. Even though we understand all these variables, but these have been all proven. The Hatha Yoga and fasting, there has been a study done by the John Hopkins Institute, and there's a big study going on with time-restricted eating. All this in the domain of dementia and improvement in dementia symptoms.